atrial abnormality or enlargement is your left atrial abnormality, commonly seen in mitral valve diseases. So you should look for atrial arrhythmias or abnormalities. The mnemonic here, so that you could remember, is that P wave or M wave shape or P wave mitrale, no, for mitral valve problems. So we have first case, a 33-year-old male dyspneic on 3 flights of stairs with a grade 3/6 diastolic murmur at the apical area. You do a 2D echo. You did a 2D echo, which showed mitral stenosis, and the blood pressure is at 110/90. This is the ECG. What is the enlarged chamber? So again, since we are in the atrial enlargement lecture part, we should look at leads V1 and lead 2. So in lead 2, take note of that P wave. And lead V1, take note of the P wave there. So you should see prolongation of your P waves in lead 2 and downsloping of your P wave of the terminal part in lead V1. So what is that? It's left atrial enlargement. So left atrial abnormality, as I've said before, you should look for the P waves in leads 2 and V1. And in lead 2, you would see prolongation of your P wave, wherein it will have a notched part in the middle part. So it will arrive at a configuration of an M letter, or what we call P mitrale. And in the V1, aside from positive deflection of your P wave, you would see that the terminal part of the P wave goes down at least one big square, or one small square, sorry. So for the second case, a 22-year-old female with shortness of breath, grade 4/6 mid-systolic murmur at the 4th intercostal space, left parasternal border, and you did a 2D echo, which revealed an atrial septal defect. This is the ECG. Again, take note of leads 2 and V1. So for lead 2, this is the P wave, and lead V1, this is again the P wave. So what's different? You would see that the P wave is of a tall P wave. It's more than 2 big squares. No? So you would see this in your right atrium. So for right atrial abnormality or right atrial enlargement, there is a tall P wave of more than 2.5 millivolts or more than 2.5 small boxes, sorry, previously. So, but it's small boxes, what we call as P pulmonale. So biatrial abnormality is the last part for atrial enlargement. When we say biatrial, both left and right atrium is enlarged. So this is how you diagnose it. There are tall P waves in lead 1, and if you have that, you're sure that you have a right atrial abnormality. But when you look also in lead V1, aside from a tall P wave, you would see that there's a normally large terminal negative component of the P wave, as seen in left atrial abnormality. And sometimes you would see also the tall P wave. But what's more important is the P wave in lead V5, wherein you would see notching of the P waves. And when you have those three, you would see, or you would diagnose this patient as having probably a biatrial abnormality. Now, to the second part, this lecture is for ventricular hypertrophy. So for the first hypertrophy of the ventricles, we'll be talking about right ventricular hypertrophy. There is normal predominant forces in the RV, which is predominantly overshadowing your left ventricular forces, because normally your left ventricle has more power, has more muscle mass, no? And you should see that in leads V5, V6, you have tall R waves, no? And usually reflects long-standing and severe cardiac or pulmonary disease. So aside from that, because of this, no, with the normal configuration of R waves that are more taller in the lateral and anterior leads, in leads V1, or where we call the septal node or septal leads, which we place it in the second intercostal space, you would see more directly faces RB mass, and any increase in these RB forces is most reflected in these leads, V1 and V2. And we have this case, a 58-year-old male, 90-pack-year smoker, hypertensive for 10 years, on amlodipine 10 milligrams once a day, but however was poorly compliant with easy fatigability, shortness of breath, on limited activities and productive cough for at least 3 months. His blood pressure is at 130/80, and this is his ECG. So again, when you diagnose enlargement of your ventricles, you focus now on the precordial leads, namely your V1, V2, or your V5, V6. No? So you would see in terms of axis deviation, there is a there's a downward forces in your lead 1 as opposed to AVF, which is supposed to be of the same configuration. And with that, we have right axis deviation. V1, normally you don't see these R waves. And we have here also in leads V5, V6, which we normally see a tall R wave, is now reversed. No? So we have a tall R in lead V1 and a deep S in leads V5 and V6. And take note of those numbers, because this is how we diagnose right ventricular hypertrophy. So clinical significance of right ventricular hypertrophy are as follows: COPD, long-standing mitral stenosis, left to right shunts with isomerization, which signifies pulmonary hypertension. There are differentials such as infero-posterior MI, right bundle branch block, hemiblocks, and your Wolff-Parkinson-White syndrome. Last is your left ventricular hypertrophy. As the surface area of their LV increases and the myocardium moves closer to your precordial electrodes, there is an increased amplitude or duration will be recorded on your chest leads. So unlike your RVH, we have some criteria that probably you should take note, no? In diagnosing left ventricular hypertrophy or LVH. So you have Sokolow-Lyon, your Romhik-Estes, and your Cornell voltage. So because it's the left ventricle that is involved, you focus now your eyes to leads, again, V1, V5, and V6. And take note that when you have left ventricular hypertrophy as seen in Romhik-Estes, normally your QRS duration becomes slightly prolonged. Huh? And there is intrinsicoid deflection of your R wave in V5, V6. Now we're down to the last chamber enlargement, which is left ventricular hypertrophy. So when you say left ventricle, it's located posteriorly, and as the surface area of your left ventricle increases and the myocardial moves closer to the precordial electrodes, there will be increased QRS amplitude in the lateral leads, which will be recorded on your chest leads. And for LVH, there are common diagnostic criteria. Unlike your RVH, it's simply just looking into those, V1 and V5, V6, and axis deviation. But here we have certain criteria which have point system, like your Romit-Estes, your Sokolov-Lyon, and your Cornell voltage criteria. So focus yourselves on, again, leads V1, V5, V6. And for LVH and RVH as well, there would be a prolongation or your QRS to more than 90 milliseconds. So it's part of your ventricular hypertrophy. No? And normally also, there would be intrinsicoid deflection of your R waves in V5, V6, meaning your start of your Q to your start of your R, it's increased by more than 50 milliseconds. And take note of that point, no, because if you have more points for the Romit-Estes and you accumulated 4 probable LVH, and if you have 5 definite LVH. So we have this case, a 64-year-old female, hypertensive for 20 years on losartan 50 milligrams once a day, diabetic for 13 years on metformin with no heart failure or anginal symptoms. Her usual blood pressure at the clinic is at 160/90, and usual blood pressure at home this morning is at 150/90. So with that, you can say that she has uncontrolled blood pressure. And you got an ECG, and this is what it looks like. So again, we're talking about ventricular hypertrophy. You focus on your precordial leads, particularly on leads V1, V5, V6. So for leads V1, you measure the S wave. And with that, you have 2.4 millivolts in this case. And for leads V6, you measure the R wave, which is at the height of 3.1 millivolts. So put it together, you have a total of 5.5 millivolts. And aside from that, your AVL is also increased in terms of the height of the R wave, which is more than 1.1 or at 1.3 millivolts to be exact. So for the Sokolov-Lyon criteria, you would take note of these lead changes. So take note of that. If you have 3.5 millivolts of your S in V1 plus R in V5, then you can diagnose LVH, or if you have a tall R wave in lead AVL of more than 1.1 millivolts, you have LVH. So remember those. You keep adding this R wave and S wave, and take note of these leads. The lateral leads in particular have high or tall R waves. Unlike the RVH, you just get the ratio here, you summate it. Another one you can use is another criteria. You take note of the deep S wave in V3, which is at 1.5 millivolts, and again, your R wave in lead AVL of 1.2 millivolts. So all in total, you would see that this patient has 2.7 millivolts in total. And since she is a female, for that, you fulfill the criteria for the Cornell voltage, which is at more than 2 millivolts for this combination of S and R wave in V3 and AVL respectively. But for men, it should be more than 2.8 millivolts. So for left ventricular hypertrophy, why is detection of LVH important? What is the next step when you detect LVH on ECG? And last question is, what are the steps in the management of patients with hypertension and left ventricular hypertrophy? Please take note of these 3 questions. And the clinical significance of left ventricular hypertrophy is that it's due to increased pressure in your left ventricle or increase in afterload in the left ventricle caused by hypertension, aortic stenosis or regurgitation, CAD or coronary artery disease, ventricular septal defect, or your patent ductus arteriosus. No? Other differentials is your anterior MI, LBBB, and your Wolff-Parkinson-White syndrome. So I'll be leading you with this last case. A 64-year-old female, hypertensive, on losartan, diabetic for 13 years, metformin, and this is again the usual blood pressure, sinus rhythm, left axis deviation, LVH with strain pattern, and if you encounter these types of patient, what will you do in this case? Thank you.
The presentation for today will deal with hypertension among high-risk patients. For my disclosure, this lecture received educational grant from Boehringer Ingelheim. For the presentation, we will discuss the impact of hypertension on cardiovascular health, then present the risk stratification strategies based on the most recent international guidelines, and review their recommendations and some studies as basis for the strategy of treating high-risk patients. This is an important topic since hypertension is one of the most common conditions that predisposes to organ damage. It can lead to heart enlargement, particularly left ventricular hypertrophy. Other clinical events that could occur to patients with hypertension and can be identified by ECG are myocardial infarction, atrial fibrillation, and ventricular arrhythmias. Elevated blood pressure is a common condition, and it remains among the leading cause of morbidity and death globally. It has an independent and continuous relationship with the incidence of several cardiovascular events, including hemorrhagic and ischemic stroke, myocardial infarction, sudden death, heart failure, as well as peripheral artery disease and end-stage renal disease. It is therefore critical to improve the identification and management of hypertension, particularly those who are at high risk of developing clinical event, to reduce the burden of morbidity and mortality. Because of these potential consequences, quantification of a person's risk of developing a cardiovascular event over a defined period is an important part of the risk stratification process for patients with hypertension. 2017 American College of Cardiology guideline recommends assessment of risk as a guide for initiation of treatment by identifying presence of cardiovascular disease and use of ASCVD risk score that includes age, sex, race, total cholesterol, HDL cholesterol, systolic BP, blood pressure lowering medication use, diabetes status, and smoking status. This calculator is developed from cohort studies. The 2018 European Guidelines on Management of Hypertension recommended use of the Systematic Coronary Risk Evaluation, or SCORE system. This table shows that those with established cardiovascular disease, renal disease, or diabetes, a markedly elevated single risk factor like cholesterol, or hypertensive LVH, are considered high and very high risk. While CV risk assessment using SCORE calculator or chart is recommended for hypertensive patients who are not already at high or very high risk classification. This is the score system presented in a chat format. This is also available in the form of risk calculator apps. The score system estimates the 10-year risk of a first fatal atherosclerotic event in relation to age, sex, smoking habits, total cholesterol level, and systolic blood pressure. The estimated risk should also be complemented by the assessment of hypertension-mediated organ damage, or HMOD. These are structural or functional alteration caused by elevated blood pressure. Their presence have adverse prognostic significance and may lead to a high severe risk even in the absence of classical risk factors. Patients with low or moderate overall risk can be reclassified due to presence of HMOD, providing therapeutic guidance and helps in selection of drug treatment. The latest guideline, the 2020 International Society of Hypertension Global Hypertension Practice Guidelines, supports the ACC and ESC recommendation that risk should be assessed in all hypertensive patients and favors the easy-to-use risk estimation based on BP levels and additional risk factors for a simplified approach. Overall, this figure visually presents the level of risk of a patient with hypertension according to blood pressure levels, presence of cardiovascular risk factors, HMOD, or comorbidities. The initial risk stratification directs the decision regarding treatment. This is the general guide for initiation of treatment. All patients should be advised on lifestyle modification. Pharmacologic intervention should be commenced right away among those who are risk stratified as high risk, as well as those who are at higher range of blood pressure. Pharmacologic treatment is given to those considered at low to moderate risk if BP is not controlled after 3 months of lifestyle modification. ESC is consistent with latest ISH guideline with this approach. ACC is generally similar in immediate treatment of high-risk patients based on ASCVD score and recommends use of BP-lowering medication for primary prevention of CVD for adults with risk less than 10% and a systolic BP of 140 or higher or a diastolic BP of 90 or higher right away. The first objective should be to lower blood pressure to less than 140/90 in all patients. Provided that the treatment is well tolerated, treated blood pressure values should be targeted to 130/80 or lower in most patients. In older patients, systolic BP should be targeted to between 130 and 140, and diastolic BP to less than 80. In general, treated systolic BP should not be targeted to less than 120. The target are consistent among the three guidelines. ISH just emphasized that in low-resource setting, the essential standard or minimum standard of care is to at least target BP reduction by 20/10 mm mercury, ideally less than 140/90. The three guidelines have the same basic drug treatment strategy. Based on the results of RCTs showing clinical events reduction, proven BP lowering effectiveness, and similar effect on overall cardiovascular morbidity and mortality, all 5 major drug classes are recommended as a general basis of treatment. They can be combined with one another except for ACE inhibitors and ARBs. The ACC and ISH also recognize the 5 classes of drug, specifying beta blockers used at any treatment step for specific indications such as heart failure, angina, ischemic heart disease, atrial fibrillation, young woman with or planning pregnancy. Important part of the strategy is the recommendation for combination therapy and preference for a particular class of drug. The 3 major organizations' core drug treatment strategy emphasized on 2 things: the advantage of combination therapy and preference for certain class of drugs. The goal of this core strategy is to have better BP control, prevention and improvement of HMOD, and reduction of risk of clinical events. Studies had shown that to achieve a BP target in most patients of less than 130/80, the majority of patients will need combination therapy. Initial combination treatment is consistently more effective at BP lowering than monotherapy, and even low-dose combination therapy is usually more effective than maximal dose monotherapy. Drug regimens with complementary activity targeting multiple mechanisms, where a second antihypertensive agent is used to block compensatory responses to the initial agent or affect a different pressure mechanism, can result in additive lowering of blood pressure. Two drug combinations as initial therapy have been shown to be safe and well tolerated. This may also improve adherence due to better tolerance, so combination therapy is recommended at the initiation of treatment. Exceptions are frail older patients and those at low risk with grade 1 hypertension, particularly if systolic BP is less than 150. The guidelines recommend that hypertension treatment should be preferentially based on combinations of an ACE inhibitor or ARB with a calcium channel blocker and or a thiazide-like diuretic. This is based on the following reasons. Combination therapy that includes an ACE inhibitor or ARB with either a calcium channel blocker or diuretic are complementary because both calcium channel blocker or diuretic activate the renin-angiotensin-aldosterone system, which will be counteracted by their combination with an ACE inhibitor or ARB. These combinations also limit potential adverse effects associated with diuretic or calcium channel blocker monotherapy, reducing the risk of hypokalemia due to diuretics and reducing the prevalence of peripheral edema due to calcium channel blocker. These combinations also ensure RAS inhibitions as part of the treatment strategy, which is an important consideration for many high-risk patient groups. The guidelines favor the use of combinations of two antihypertensive drugs in a single pill because in addition to the favorable effect of complementary action of the combined drugs, reducing the number of pills to be taken daily improves adherence and further increases the rate of BP control. These combinations are now widely available in a single pill and a range of doses, facilitating simplification of treatment. At present, the availability of two-drug single-pill combinations is largely among RAS blockers, with either a calcium channel blocker or diuretic being the ideal combinations. ISH indicated that in low-resource setting, where access to this strategy is limited, clinicians may have to resort to free combinations of whatever drug is available, recognizing the rational possible combinations based on the individual characteristics of the drugs. This core treatment strategy is valuable for management of high-risk patients, considering that many hypertensive patients have other comorbidities that can affect cardiovascular risk and treatment strategies. These conditions include vascular disease, CKD, heart failure, and diabetes mellitus. In addition, many have underlying HMOD even they don't have the aforementioned conditions. This makes many hypertensive patients high risk, as pointed out in the risk stratification process. This core drug treatment strategy can lead to early BP control by assuring better BP lowering effect as well as compliance. Observational studies had shown that time taken to achieve blood pressure control is an important determinant of clinical outcomes. A shorter time to achieve control is associated with lower risk. More importantly, preference for RAS inhibitors provide evidence-based therapy proven to reduce clinical events among high-risk patients as well as favorable effects on hypertension-mediated organ damage. The preferred class of drugs for high-risk patients are RAS inhibitors because of their proven effectiveness on reduction of cardiovascular, renal outcomes, as well as prevention and regression of HMOD. RAS inhibitors are widely used antihypertensive agents, particularly ARBs, because of its known better tolerability and had been evaluated among high-risk patients. At this segment, we will review some trials that lend support to use of RAS inhibitors in the core treatment strategy particularly HOPE trial that used ACE inhibitor ramipril and larger trial on ARB on target that used telmisartan. This is a landmark trial that established the role of RAS inhibitions in reduction of cardiovascular outcomes among high-risk patients. The study assessed the role of an ACE inhibitor ramipril in more than 9,000 patients with vascular disease or diabetes, plus one other severe risk factor, and who were not known to have heart failure with reduced ejection fraction. They were randomly assigned to receive ramipril 10 mg daily or placebo for a mean of 5 years and monitored for incidence of MI, stroke, or cardiovascular death. The study established that ACE inhibitor ramipril significantly reduced the rates of death, MI, and stroke in a broad range of high-risk patients. Each component of the primary outcomes were reduced. Moreover, there was also reduction of overall death, revascularization, cardiac arrest, and heart failure, as well as diabetes and its complications. These benefits of RAS inhibition could be explained by attenuation of angiotensin II that leads to anti-atherogenic, anti-fibrotic, anti-thrombotic effect, and improvement of endothelial function. In this study, it was also observed that more patients in the ramipril group than in the placebo group stopped treatment because of side effect of cough. This trial demonstrated the clinical benefit of RAS inhibition among patients who are at high risk for cardiovascular events. Same group of investigators compared ramipril to telmisartan, an ARB with longer half-life, higher receptor affinity, and lipophilicity relative to other ARBs among high-risk patients based on presence of vascular disease or high-risk diabetes. Like ACE inhibitors, ARBs attenuates angiotensin II and have protective effects similar to those of ACE inhibitors but with better tolerability. OnTarget is one of the largest trials conducted for this clinical concern. The study recruited more than 8,000 patients for telmisartan and ramipril arm with median follow-up of 56 months. The primary aim is to evaluate if telmisartan is at least as effective as ramipril in reducing the incidence of cardiovascular death, MI, stroke, or hospitalization for heart failure among high-risk patients. Most of the patients are already on statins and antiplatelets. The study showed that telmisartan is as good as ramipril, with tests for non-inferiority showing statistical significance based on primary outcome of OnTarget. They also look at the primary outcomes evaluated in HOPE trial to see if telmisartan will provide the same benefits, and it also showed significant non-inferiority, confirming its benefit. And with regards to tolerability, there was an advantage with telmisartan with more patients discontinued ramipril because of cough or angioedema compared to telmisartan. Based on this study, it had been shown that ARBs using telmisartan is as beneficial in reducing incidence of clinical outcomes among high-risk patients and more tolerated than ACE inhibitors. The investigators also assessed whether telmisartan would be effective in similar high-risk patients intolerant to ACE inhibitor in Transcend trial. Majority of the patients are already on statins and antiplatelets due to their high-risk features. The study result did not reach statistical significance on the primary outcome, which included hospitalization for heart failure, while for same composite outcomes in the HOPE trial, which include cardiovascular death, MI, or stroke, the study showed significant reduction with telmisartan. Summarizing the data from these studies, HOPE trial showed reduction in rates of death, MI, stroke, heart failure, and revascularization with ACE inhibitor. OnTarget in turn showed that telmisartan is as good in reducing the same outcomes, including hospitalization for heart failure, and the primary outcome in the HOPE trial, with significantly better tolerability compared to ACE inhibitor. Furthermore, among ACE-intolerant patients, Transcend also showed reduction in the risk of the HOPE primary outcomes. These benefits were observed among patients who were already taking aspirin and lipid-lowering agents. The presented clinical trial data support the use of antihypertensives within the class of RAS inhibitors among high-risk patients with further practical advantage of telmisartan because of better tolerability. Patients had been shown to have better adherence with ARBs based on many studies, as summarized in this meta-analysis of Cornish. This characteristic is very important in the clinical setting. As recommended by the guidelines, combining them with other drug class based on their complementary action will further improve tolerability and BP lowering efficacy. This study by Neldam et al. Demonstrated the enhanced efficacy with combination, showing that telmisartan combined with CCB provides better BP lowering than doubling the dose of CCB in patients not at BP goal. The efficacy of the combination had also been established in a broad range of hypertensive patients at risk. This diagram is helpful as a guide for rational combination of different classes of drugs. Combining ARBs to CCB or diuretics is preferred to further improve adherence and BP control and achieve risk reduction. Overall, the management strategy for patients with hypertension who have high-risk feature should be based on treatment proven to reduce risk of morbidity and mortality. It should provide simple dosing regimen, combination therapy in most patients, and preferably single pill combination. The treatment strategy should always consider accessibility, and the drug should be well tolerated as indicated by the 2020 ISH guide. For this strategy, we need to adopt an enduring, versatile, and persevering drug treatment, one that provides 24-hour BP protection, promotes adherence due to convenience and tolerability, and lastly provides good CB protection beyond BP lowering. In summary, high-risk patients should be routinely identified because of dire consequences if not treated properly. For these patients, early treatment at any stage of hypertension should be initiated using combination therapy with a RAS blocker because of proven clinical benefit. In addition, prognosis-modifying treatments such as antiplatelet and lipid-lowering therapy, as indicated, should be part of the holistic management. Thank you for your kind attention, and have a good day.
Announcements and house rules. Please ensure that you have a strong and reliable internet connection for an optimal ECG course experience. The UP-PGH Division of Cardiovascular Medicine will be the host of this course. Post your questions for the panelists in the Q&A box. Vote in our ECG challenge quizzes, which will be given during the first 3 days of the course. View the scientific program at a glance on our brand new ECG course website at dcvm.org.ph and get a chance to win exciting prizes. Visit our sponsors' virtual booths and join in the ECG course scavenger hunt. Mechanics for our grand raffle will be posted on the ECG course website. A certificate of attendance will be sent via email to attendees who successfully completed the 4-day course and accomplished the post-activity attendee course evaluation Google form. This course will be recorded by the organizers. 4 ECG course lectures will be available for a limited time on the website even after the conclusion of this event. Thank you for supporting the UP-PGH Division of Cardiovascular Medicine's 44th ECG and 2nd Clinical Cardiology course.
Okay, let's start quiz number 3, for our second day. So our first question, so we listened to your feedback. Some of you had problems with answering the poll because of you're on a cell phone, and I think the Zoom app behaves differently. So what we'll do is I will start the poll once I think you've looked at the question, and the poll will start only if I say so. Okay, and I'm going to have some slides just showing both the ECG and the question. Okay, so this is our first ECG. Okay, take a look at our ECG pretty well. Look at the regularity, presence of P waves, look at the voltages of their QRS, and look at their axis. So the question is, so look at the ECG, what chamber enlargement is most likely given this ECG? Okay, so which chamber is enlarged? A, left ventricle, B, right ventricle, C, left atrium, or D, right atrium? Okay, so the question is, what chamber is enlarged? What chamber enlargement is more likely? Okay. So this is the question again. Okay, we can start the poll now. Okay, let's see our answers. Okay, a lot of you answered, so 47% answered right ventricle. Next, second to that is left ventricle. Okay, let's go back to the lecture of Dr. Llanes. Okay, so look at the, see if I can annotate this here. So in V1, you expect actually your R wave to be small and your S wave to be deep. Okay? But here your R wave is tall. Okay? So you have a tall R wave, and look at V5 and V6. You expect your S waves or your negative waves to be very small or almost absent, okay, in V5, V6. But here they're very, very deep. Okay? And then if you look at the axis, one is negative, your AVF is positive. Okay, so if you're using your thumb method, you will see that your right thumb is up, okay, and that is right axis deviation. So given the right axis deviation, the tall R in V1 or V2, deep S waves in V5, V6, this is right ventricular hypertrophy. Okay, so this is our second ECG. Okay, again, same question, what chamber is enlarged? Okay, given this ECG, what chamber is enlarged? Is it the left ventricle, the right ventricle, the left atrium, or the right atrium? Okay, I think we can start the poll. Okay, let's see the answers. Okay, a lot of you answered. So 85% answered left ventricle, which is the right answer. Okay, so you can see, let's use the larger version of the ECG, okay, that your S wave, okay, in V1 is very deep, and your V5, V6 R waves are very tall, and if you get the voltage of S, okay, and the voltage of R in V5, V6, your S in V1, it's more than 35 millimeters. That will satisfy your Sokolow-Lyon criteria. And an interesting note, even Sokolow and Lyon, notice that you have, for true LVH patients, you have this strain pattern or ST segment depression in your anterior and lateral leads. Okay? And actually, some of the other criteria take that into consideration. Okay? If it's just your voltage, then your probability of having actual LVH is lower than if you have both the voltage and the so-called strain pattern. Okay, so here in this is the last ECG for this quiz. Okay. Look at your ECG, look at your P waves, look at your voltages again. Okay. Look at your P wave duration. I might be giving a clue by pointing it out. Okay, what pair of possible chamber enlargement is seen in this ECG? I say possible because imaging is still king. I always say that you don't really diagnose chamber enlargements strictly just on the ECG. So you still use imaging modalities like your X-ray, your physical exam, your and your echo, okay, to really dial in the diagnosis. Okay, so this is just usually for ECG, it's a clue. Okay, so what pair of possible chamber enlargements? Is it left atrial and left ventricular, left atrial and right ventricular, right atrial and left ventricular, or right atrial and right ventricular? Yeah, I think you can start the poll. Okay, let's see the answers. Okay, so a lot of you, 66%, answered right atrial and left ventricular, which is the correct answer. Let's look at the ECG again. Okay, you can see here, okay, I already pointed it out, the P wave is tall and peaked. What do you mean by peak? Usually I playfully say it's peak if you sit on it, it hurts. So matulis siya. Okay? And then the P wave is tall. Okay? So that's right atrial abnormality or right atrial enlargement. Okay? So tall means more than 2.5 millimeters or 2.5 small squares. And it's not wide, it's not that wide. So around mga 3 squares, because more than 110 milliseconds is a wide P wave. So wide P wave and a really deep secondary component in V1 for that would be left atrial abnormality. And again, you can see here the deep S waves in V1 and the tall R waves in V5, V6, which will satisfy your voltage criteria for LVH. Okay, so let's go on to our next lecture.
Protecting the heart and the kidney will prevent the early, frequent, and fatal complications of type 2 diabetes. Forxiga is now approved in the Philippines for the prevention of heart failure or cardiovascular death in type 2 diabetes patients with and without cardiovascular disease. Do not delay. Protect the heart. Protect the kidney. Today.
To discuss the topic entitled Ischemia and Infarction, let us all welcome Dr. Jaime A. Herrera.
Hi, good afternoon. I'm Dr. Jaime A. Herrera from the Division of Cardiology of UPPGH, and I was tasked to lecture to you the topic of ischemia and infarction on an ECG. Let me share my screen. Okay. So the objectives of this 20-minute lecture will be at the end of this activity, you should be able to define and differentiate myocardial ischemia and infarction. You should be able to identify ECG criteria and signs of myocardial ischemia and infarction. And you should be able to know the approach to the diagnosis and management of ischemia and infarction. So before we proceed, you will be hearing these terms a lot in the next few slides. The ST segment, the J point, J60, J80 point. When we say the ST segment, as discussed in your previous lectures, we refer to this segment, from the J point to the ST segment. And it's basically this segment. When we talk about the J point, it is this point right after the QRS and before the ST segment. When we talk about the J60 point, we mean 60 milliseconds after the J point. And if you hear me later talk about or mention J80 point, that's actually 80 milliseconds after the J point, or 2 small boxes. The PR segment, this one here, is the baseline or the reference line for measuring deviations of this ST segment. Okay? So for example, when we talk about ST elevations, again, this is the ST segment and this is the J point, and this is the reference point or the PR segment. We are pertaining to the magnitude of elevation of this ST segment, and it's usually measured at your J point. And when we say ST depression, we talk about the depression or the decrease in the magnitude of this segment relative to the PR segment. We usually use the J point again, or some literature or references would actually recommend using the J60 or even the J80 point, especially during stress test. So just as an example, when we say ST elevation, we are pertaining to elevation of this segment and the J point relative to the PR segment. And as you can see here, the ST elevation is equal to 4 millimeters in magnitude. In this case, we are talking about ST depression relative to the PR segment, and you can see that the J point or the ST60 is depressed, or it has a lower magnitude by about 3 small boxes below the PR segment or reference line. So I will be discussing 2 cases for this lecture, and let's proceed with the first case. A 60-year-old male who consulted for chest pain. He has good functional capacity, he is diabetic, he is hypertensive, and is poorly compliant to his medications. He had intermittent chest discomfort for about 6 months prior to consult, and it was described as chest pain on exertion, lasting for 5 minutes, relieved by rest. It happens 2 to 3 times a week, and due to the persistence of symptoms, he went to your clinic. So what is your impression? Okay. So this is actually chronic stable angina pectoris, or in other terms, ischemic heart disease or coronary heart disease. And it is usually characterized by an inadequate blood supply to the myocardium, usually due to blockages in the epicardial coronary arteries. So the case is actually very typical of CSAP, or chronic stable angina pectoris. Next, what are the basic cardiovascular diagnostic tests that you will order for this patient? The very first, or the very basic test that you should order is an ECG. So let me give you a few seconds to try to interpret. Okay, so the interpretation of this ECG based on your previous lecture is actually regular sinus rhythm, normal axis, and left ventricular hypertrophy. Okay. Next question is, do you see any signs of ischemia? Okay. So the answer is no. There are no signs of ischemia in this tracing. And when we say ischemia, what do we mean? So this is the ECG criteria of ischemia. And when we say ischemia on ECG, we basically refer to ST depressions or T-wave changes or T-wave inversions. No? So ST depression is basically defined as some more than or equal to 0.05 millivolt depression in two contiguous leads. What do I mean by contiguous leads? We'll be discussing that later. But just remember, ST depression is 0.05 millivolts depression or a decrease in the magnitude relative to your PR segment as discussed earlier. Okay? When we say T-wave inversion, the basic criteria is more than or equal to 0.1 millivolt inversion of your T-wave in two contiguous leads with a prominent R wave or an RS ratio of more than 1. So these are examples of the definitions I mentioned earlier. You can see that this is a PQR-ST complex, and the ST depression is shown or highlighted by the red arrow. You can see that this segment is lower or depressed relative to this PR segment over here. And when I talk about T-wave inversions, normally a T-wave should be upright in leads with a prominent R wave, but you can see in this case, the T-wave is inverted, and it has a magnitude of about 7 small boxes, okay? So again, just to re-emphasize how to measure ST depression, we use the J point or the ST60 or 80 relative to the PR segment. And in this example, you can see that the J point or the ST60 is much lower than this PR or isoelectric line. And it's about 2 millimeters depressed. In this tracing, you can see that the J point or this ST60 or 80 is depressed relative to this PR segment by about 1.5 millimeters ST depression or 1.5 small boxes. So going back to the patient's tracing, again, basically we do not see evidence of T-wave inversions or ST depressions. But is this possible for a patient with typical angina? Well, the answer is yes, no? Because a resting ECG will not rule out coronary artery disease or ischemia. And the best way to document ischemia in patients with a normal ECG and yet presenting with chest pain or typical angina is a treadmill exercise test. So in this test, we usually ask a patient to undergo exercise using a treadmill. We attach them to the monitor and we monitor for ST segment changes, ST depressions, ST elevations, or even T-wave inversion. Now on a treadmill, we don't usually commit to a positive test just because an ST depression is present. We usually look at the characteristics of the ST depression. And in this slide, you will see 3 types of ST depressions. 1 is the upsloping ST depression. 2 is the downsloping ST depression. And 3 is the horizontal ST depression. Upsloping ST depressions are usually not conclusive for ischemia. And in some cases, it might even be negative. We don't consider this as a positive test on stress testing. What we usually consider as significant are downsloping and horizontal ST depressions. Downsloping meaning the slope of the ST segment depression points downward or points to a negative slope. And horizontal is if it is flat or the slope is flat. Okay. So for the criteria of downsloping ST segments, usually the J point and ST80 depressions are 0.1, and the slope or the ST segment slope is -1, meaning it downslopes. Similar to this tracing over here, you can see that the J point is depressed relative to the PR segment, and the slope of the ST depression is negative. meaning it is a downsloping ST segment. When we talk about horizontal ST depressions or ST segment depressions, we pertain to a J point and an ST80 depression that is 0.1 millivolt or more, and the slope is within the range of 1, meaning it is almost flat, similar or as evidenced in this tracing. You can see that the J point and the ST80 are depressed, and you can see that the depression relatively has a flat slope. So, for example, we subjected this patient to a stress test, and this is the result, or this is the tracing of his stress test at stage 2. So you can see that the ST segments are depressed, and the ST depression is somewhat straight or horizontal, or the slope is equal to 1. This suggests that there is the presence of a horizontal ST depression. And if you add that up with the symptoms of this patient, we would actually conclude this test to be positive. Okay, so just to summarize the ECG criteria of ischemia, ST depression is defined as 0.05 millivolt or more depression in 2 contiguous leads, and the T-wave inversion is defined as a more than 0.1 millivolt inversion of your T-waves in 2 contiguous leads. A positive test for ischemia is usually defined as a downsloping ST segment, similar to this tracing, or a horizontal ST segment depression, similar to this tracing. And as mentioned earlier, a rapidly upsloping ST segment depression is usually negative for ischemia on treadmill stress. However, this patient was non-compliant to the medications that you prescribed and was lost to follow-up. 2 hours prior to consult, he had sudden onset of severe pain with diaphoresis radiating to the left arm. And this time, this pain is not relieved by rest or nitroglycerin. He was received at the ER with a borderline blood pressure, a fast heart rate, no neck vein distension, clear breath sounds, a soft S1, and no murmurs. So clinically, what is your current impression? Obviously, by testmanship, this is an acute myocardial infarction. Now, what will you do next? Okay. So this pathway was lifted from the ACC or AHA guidelines for the management of ST segment elevation MI. Now, when you see a patient with chest pain and the symptoms are highly suggestive of an acute coronary syndrome, the guidelines would actually recommend that an ECG be done within 10 minutes. Okay? And this is actually done to triage patients who are actually NSTEMI or NSTE-ACS or STEMI, because management would actually differ significantly. Now, just as an overview, for an acute coronary syndrome, just to oversimplify things, we usually talk about two types of ACS. One is NSTEMI and the second is STEMI. Both will present with chest pain. Both will present with elevations in your biomarker. But the basic change or the basic differences would lie on their ECG changes. And STEMI would usually show signs of ischemia, such as ST depressions or T-wave changes. Whereas ST elevation myocardial infarction, from the word itself, would actually show ST segment elevations on your ECG. Criteria for an ST elevation on ECG that is compatible with an MI or a STEMI. 1, there is new ST elevation at the J point in 2 contiguous leads with the following cutoffs. So it's actually 0.1 millivolt or 1 small square in all leads except in lead V2 and V3. In lead V2 to V3, it will actually depend on the sex and age. For males, it's actually an elevation of your J point by 2 small boxes or 0.2 millivolts. For men younger than 40 years old, it actually refers to an ST elevation of 2.5 small boxes or 0.25 millivolts. And for women, the cutoff is lower. It's 1.5 small boxes or 0.15 millivolts. This is a diagram, no, for easy remembrance of the criteria that I showed you earlier. In all leads, it's usually 1 millimeter elevation. But in V2 to V3, the cutoffs would vary depending on sex. And for males, it also varies depending on age, with a cutoff of 40 years old. So this is an example of how we measure ST segment elevation. From the earlier tracing, or from the earlier slides, again, we identify the PR segment, and you identify the J point, and you compare the magnitude, or you determine the magnitude of elevation of this J point. For example, in this slide, this is the PR segment, and this is your J point. You can see that the boxes here would equal to 1.5 millimeters, or 0.15 millivolts. And in this slide, this is the PR segment, and this is the J point. You can see that the ST elevation, or the J point, is elevated by about 2 millimeters, or 2 small boxes, or 0.2 millivolts. So when the patient came in, this was his ECG tracing, and the troponin was significantly elevated. So I'll give you a few seconds to try to read this tracing on your own. Okay, so before we interpret the ECG, let me share a few slides on how to localize myocardial infarction and its corresponding coronary artery using an ECG. So this is the gross anatomy of the heart, and as we all know, the heart is supplied by your right coronary artery, your left anterior descending branch, and your left circumflex branch. The origin of the left circumflex and the LAD is the left main coronary artery. No? And in your ECG, on your ECG, the left anterior descending branch is usually represented by your V1, V2, even V3 and V4. Your left circumflex branch is represented by your lead 1, AVL, V5, and V6. And your right coronary artery is represented by your lead 2, 3, AVF. Your left main coronary artery in some literature may actually be represented by lead AVR. So just to summarize, lead 1, AVL, V5, and V6 would correspond to the lateral wall of the heart. V1, V2, V3 to V4 would correspond to the anterior or the anteroseptal wall of the heart. Lead 2, 3, and AVF would correspond to the inferior segment of the heart. So to interpret this ECG, this is regular sinus rhythm with note of ST elevations and lead V3, V4, V5, V6, lead 1, and AVL, which would correspond to your anterolateral wall. So this is a STEMI of the anterolateral wall, probably involving the LAD and or the LCX, or even the left main. So to summarize, the ECG criteria for ischemia and ST elevation is shown on the screen. Ischemia would refer to ST depressions or T-wave inversions, whereas infarctions would equate to ST elevations, defined as the following. So once a diagnosis of STEMI is made, urgent referral to cardiology is a must, and the patient must be assessed if he or she is a candidate for primary PCI. So that's how important the ECG is in patients presenting with chest pain. So to end my lecture, these are the important points to remember. 1, angina is the most common manifestation of ischemia and infarction. Significant ECG findings for ischemia would include ST depressions or T-wave inversions, and it is important to note that a normal ECG or a normal resting ECG does not rule out coronary artery disease or ischemia. Significant stress test findings compatible with ischemia are your downsloping and horizontal segment ST depression. An ECG is a vital diagnostic for ACS, and these are the following significant findings for a STEMI, or an ST elevation MI. And appropriate and timely management should be given to patients with ACS, especially those with ST segment elevation. So thank you.
ECG Course Grand Raffle Mechanics. Get a chance to win a 13-inch MacBook Pro, an iPad Pro, an 8th Gen iPad, a SanDisk 500GB portable SSD, or a second edition ECG handbook. Terms and conditions. To be eligible for the raffle draw, the participant must fulfill the following criteria. Must be present for all 4 days of the ECG course. Daily Zoom registration will be checked. Must get a score of at least 8 out of 15 points on the Dr. Rodici LRI TerraPharma quizzes by voting on the polls. Chatbox votes will not be counted. Must get a score of at least 50% in the ECG course scavenger hunt in the ECG course website, dcvm.org.ph. Must be present during the grand raffle draw during the last day of the ECG course. Join the ECG course scavenger hunt in the ECG course website, dcvm.org.ph, by clicking on the link to the scavenger hunt Google form. Fill up the scavenger hunt Google form by finding the answers in the ECG course website sponsors virtual booths. To win in the raffle draw, the participants must be online and must confirm their presence via private message in Zoom. If the participant is not present when called, another name will be drawn. By participating in the ECG course grand raffle, the attendee agrees into the terms and conditions of the UPPGH Division of Cardiovascular Medicine Data Privacy Statement.
Welcome to the Optimal Medical Therapy in CCS, a personalized approach scientific lecture. Generously sharing his knowledge as our speaker is Dr. John C. Añonuevo. He is the chairman of the Department of Medicine of the UP Philippine General Hospital. He is also a professor at the UP College of Medicine. Let us welcome Dr. John C. Añonuevo.
Today, we will talk about optimal medical therapy in chronic coronary syndromes, a personalized disclosures. Would like to understand the new concepts of chronic coronary syndromes and translate the implications of the 2019 ESC CCS guidelines. Second is define what is optimal medical therapy. And thirdly, discuss the role of metabolic modulation and heart rate control in the management of CCS patients. You just had a lecture about EKG changes suggestive of myocardial ischemia, and you notice that you find ST segment depression and T-wave changes. And for today, we will discuss about how to effectively manage patients with myocardial ischemia. Start with what we know, the old concept of what we know as ischemic heart disease. We know that we've been taught that ischemic heart disease is caused only by atherosclerotic obstructions of the cardiac coronary vessels. Second, the demonstration of such obstruction is the key to diagnosis. And thirdly, removal of coronary obstruction is always the key to treatment. It's not as simple as that because many ischemic heart diseases have no epicardial coronary artery obstruction. In a study of about 661,000 patients who had positive treadmill stress tests and significant symptoms of chest pain, more than half of them had actually non-obstructive coronary artery disease. of about 12,000 patients with acute coronary syndromes, about 9 to 10% of women actually had no coronary artery disease, and close to 30.5% of patients with unstable angina who are women had no documentation of a significant coronary artery disease. Findings, we have been introduced now to the multifactorial origin of ischemia, where we talk not only of diffuse epicardial CAD, as you see here, or focal epicardial CAD, but also other possibilities like vasospasm, myocardial bridging, and most importantly, microvascular dysfunction. Talks about how important is the recognition of the different factors that affect coronary blood flow. Coronary blood flow is the pressure difference between aorta, proximally and distally down into the capillaries. And you can see all these factors, neural and physical factors, that can affect the flow of blood to the coronary arteries. It is also inherent that there is what you call this microcirculation from the large arteriole down to the small arterioles, where factors like endothelial, myogenic, and metabolic factors can affect vasoreactivity. The most important part of this is actually at the very end, where cardiac metabolism is able to control the flow of oxygen to the myocardial cell. Fact number 2, the demonstration of atherosclerotic obstruction is not always the key to diagnosis, because we only see 5% of the total coronary artery when we do coronary angiography. What we don't see is the remaining 95%, and that is why microvascular disease is very important to consider in patients presenting with angina and myocardial ischemia. So if you look at it now, the new theory now speaks of a multifactorial origin of ischemia, including diseases that affect the epicardial coronary arteries, the coronary microcirculation, and of course, the use of possibility of affectations in the myocardial cell, including mitochondrial dysfunction. Fact number 3, it has been shown in numerous trials that optimal medical therapy can be as good as revascularization. The very first trial in 2007, the COURAGE trial, enrolled more than 2,000 patients, which showed that PCI is as good as optimal medical therapy, or vice versa, optimal medical therapy is as good as PCI. And this was trial among diabetic patients, where the same findings were reported, although the reduction of major adverse cardiovascular events was slightly reduced in the CABG group compared to the PCI and the optimal medical. And most ischemia trial enrolled patients with stable CAD, with moderate to severe ischemia, and we know that the results documented efficacy of optimal medical therapy as good as intervention of PCI. So with that, we can say optimal medical therapy is a very good option in terms of managing patients with chronic coronary syndrome. The reason why some of the guidelines that were published in 2013, a new guideline came about in 2019 to address these new issues, to address this new paradigm about what is ischemic heart disease, what is coronary artery disease. And now we are now calling stable CAD as chronic coronary syndrome, reflecting the importance of patients with signs and symptoms of ischemia without obstructive coronary artery disease, the new terminology INOCA. Chronic coronary syndrome is a chronic and progressive disease with long stable periods, but you can see that it can be unstable at any point in time, meaning patients with chronic coronary syndrome can have acute coronary events. And the etiology for CCS can be either anatomic, which speaks of atherosclerotic plaque accumulation, or can be functional alterations of coronary circulations. Coronary syndrome can also be one of the 6 common scenarios at outpatient clinics. And other than epicardial coronary artery obstruction, now we're looking at possibility of vasospasm or microvascular disease as possible causes of angina and myocardial ischemia. The second objective of my talk is about optimal medical therapy. What is OMT? It is a treatment that controls symptoms, improves prognosis with minimal side effects and utmost adherence. And the guidelines in 2019 foster a patient-tailored approach through early combination of first and second line anti-anginal drugs. It's very important that other than the disease-modifying therapy that we are almost aware of already in terms of reduction of cardiovascular events, the use of aspirins, statins, ACE or ARBs, beta blocker, as well as the new drugs that are being discussed, specifically the value of SGLT2, one important management plan that we need to talk about is the symptomatic treatment for angina or ischemia control among our patients with CZ. And if you look at a meta-analysis that has been done covering 50 years of medical treatment, there has been no evidence to support the recognition of first or second line treatment for the management of angina. But rather, medical therapy of angina should be personalized and tailored towards the individual with an understanding of the likely pathophysiological mechanism and comorbidities. RCTs also show that anti-anginal drugs are equally effective and none of them reduce mortality or the risk of myocarditis. So if we look now specifically on what are the possible mechanism of action that we can talk about or that we can offer drugs to our patients with CCS, one of them is metabolic modulation. When we talk about metabolic modulation, we talk about the need for ATP production because ATP is the one that is used for muscular or myocardial contraction. It's important to understand the myocardial energy utilization, and we know that chemical energy in the form of fatty acid and glucose is converted to mechanical energy in the form of ATP, and as I have said, that is responsible for the energy source of the myocardium. Glucose oxidation has been found to be more oxygen efficient rather than the fatty beta oxidation. You consume more oxygen in the beta oxidation compared to the glucose oxidation. What trimetazidine does, it is able to preferentially favor glucose oxidation over fatty acid oxidation through the inhibition of the 3-ketoacyl thiolase enzyme, making the myocardium more efficient. There are some studies, this is a Russian multi-center study, that documented the benefit of adding trimetazidine on top of beta blockers, on top of beta blockers plus calcium channel blocker, even on top of triple therapy of beta blocker, calcium channel blocker, and nitrates. You can see the significant reduction in terms of angina, which is very prominent already 2 weeks after the treatment, continuously getting better and more progressive in terms of reduction. And a meta-analysis that was done by Dr. Peng documented reduction in angina attacks, reduction in nitrate consumption, increased time to 1 millimeter ST segment depression, as well as improvement in total work and exercise duration with the use of trimetazidine in patients with stable coronary artery disease. Very important, when you use drugs, you have to make sure that it is effective. And there was one study, the Ettalon study, that documented patients who were resistant to the generic trimetazidine, that when they were shifted to the innovator trimetazidine, there was significant reduction in anginal attacks and use of short-acting nitrates. About metabolic modulation, but there's another mechanism of action that would be important in the reduction of angina in patients with chronic coronary syndromes, and that is the reduction of heart rate. Elevated heart rate is a risk factor for cardiovascular death, for CHF hospitalization, for myocardial infarction hospitalization, as well as revascular risk. And ivabradine is this very unique mode of action of selectively inhibiting the phrenic current in the sinus node, which is what we know as the pacemaker of the heart. It has been shown that with therapy, the difference in terms of the first and the third visit in this study documented significant heart rate reduction with the use of ivabradine. Proves myocardial perfusion, through prolonging diastolic perfusion time, improving coronary flow reserve, and improvement of collateral function. In a nice study, which is the beautiful study, where enrolled more than 10,000 patients with coronary artery disease and LV ejection fraction of less than 40%. It has been found that in those patients with more than 70 beats per minute, the use of ibabradine on top of all the other agents led to a reduction of hospitalization for fatal and non-fatal MI, as well as reduction in the risk for revascularization. When we talk about managing our patients, it is important that we give very good combination of drugs. The early combination of ibabradine and beta blocker significantly reduce angina compared to up titration of beta blocker alone. There is also less adverse events with the combination of ibabradine and beta blocker compared to up titration of the beta blocker. So in the end, it is important that when we talk about optimal medical therapy, we make sure that we're able to control the symptoms of patients and improve their prognosis with very minimal side effects and adherence. And when we talk about that, we think about drugs in patients with chronic coronary syndrome. You might need one or more drug for angina and ischemia relief in association, of course, with drugs that are needed for event protection. The affirmation of the need for more than one anti-anginal drug as optimal medical therapy has been shown in the guidelines of CC 29. Non-adherence is quite pandemic, and it is very an important finding in the REACH registry. In Asia, close to 70% of patients is non-adherent to cardiovascular medication use. So you might have to think of drugs that can be given once a day, combination drugs like beta blockers and ibabradine. That is a very important thing when you make decisions in giving your medications to patients with CCS. Stepwise or patient-oriented categorization is very important in the management of patients with chronic coronary syndrome. The proposed stepwise approach must be adapted to each patient, given the limited evidence for various combinations in different clinical scenarios. The proposed options do not represent a formal recommendation. What does that mean? It means that as long as you know the possible mechanism, the pathophysiology of why your patient is having angina, you can actually formulate your own choice of drugs in terms of which is the first or second line drug therapy. Combination therapy is very important. You can add on already your second line drug, if we can say second line drug, the use of trimetazidine and ibabradine on top of beta blockers and calcium channel as a first step already, according to the heart rate of your patient, the blood pressure, and tolerance. So we give you the summary of my talk. As I have said, myocardial ischemia at this point in time is not only exclusively related to obstruction of your epicardial coronary arteries, but rather could be multifactorial. The recent guidelines, 2019 in CCS, represent evolution in the diagnosis and therapy of ischemic heart disease. Also, OMT has been proven to be an effective therapy compared to revascularization therapy, numerous randomized controlled trials. An individualized and personalized approach to angina treatment, which takes into consideration the patient, their comorbidities, and more importantly, the underlying mechanisms of disease is very important. Lastly, trimetazidine as a metabolic modulator offers a great advantage and has been shown to be a very effective anti-ischemic agent. And ibabradine is an effective therapy that specifically lowers the heart rate and improves myocardial perfusion that leads to less angina.
Thank you, Dr. John C. Año-Nuevo, for the informative scientific lecture, Optimal Medical Therapy in CCS, a Personalized Approach. Now, it is a privilege to introduce our moderator, Dr. Eugenio B. Reyes. He is the Chief of the Division of Cardiovascular Medicine of the Department of Medicine of the UP Philippine General Hospital. He is the past president of the Philippine Heart Association. Let us welcome our moderator, Dr. Eugenio B. Reyes.
Thank you very much. First, I'd like to congratulate Dr. Anunuevo for that fantastic lecture. Wonderfully done, very concise. And of course, I had several questions on my end, and there are several questions also posted in the Q&A box. But first and foremost, you know, this concept that you are saying, that it's not all about physical obstruction, was proven to be true in clinical trials. Did this change your practice? I mean, whenever you see patient with angina or, for example, with CAD, do you routinely do coronary angiogram, knowing that this concept is operational all the way? Dr. John?
Hello, can you hear me, Eugene?
Yes.
Okay, I have to be sure that my signal is still on. Anyway, so the question is whether we do coronary angiography in all our patients with ischemic heart disease. Is that?
No, did this concept change your practice?
Okay. Well, absolutely, Eugene. I think the reason why it changed my practice is it's really very important to identify the mechanisms involved in the ischemia of your patient, because the management of microvascular disease, vasospasm, and focal epicardial coronary artery disease is different. There are drugs that might be effective if you're talking about focal coronary artery disease, that might be dangerous to patients who probably has vasospasm. Let me just talk about one drug. Beta blockers is a drug that cannot be given to patients with vasospasm, as they're predisposing pathophysiology behind their ischemia. So it is very important to identify the exact, or if it might be difficult, but it is important to identify the nature or the etiology of the ischemia of your patients, because management is different.
Yeah. Eventually, even if you do reperfusion, ultimately the patient will still take medications, right?
Correct. Let me say one thing about that. In a study, 30%, almost 30% of patients post-PCI will come back to you with significant angina. So most of our patients with revascularization, be it in the form of revascularization through PCI or bypass, some of them would still need anti-anginal therapy.
All right, very good. Now, this next question is very important because Dr. Herrera discussed about ischemia and diagnosing it using ECG, and that is, as a review, ST depression or deep T-wave inversion. If you see this in patients with chest pain, would you right away treat this patient? You stop there and just give the medications that you have enumerated?
Okay, so it has to be a combination of the symptomatology and the EKG findings. Angina is a very important factor in the management of patients with chronic coronary syndrome because it portends usually a poor prognosis if you have significant angina. So if you have a patient with EKG changes and is symptomatic, I think that's enough basis already for you to start medical therapy.
And you have discussed two important drugs. I think both of them are hemodynamically safe. No changes in blood pressure, except for one, ivabradine reduces heart rate. There is a question here from coming in from the chat box. Is there a role for ivabradine in heart failure with paroxysmal atrial fibrillation?
Okay.
Very nice question.
Very nice question. Very nice question. Okay. I will answer that two ways. There is a role for ibabradine in heart failure. Okay, ibabradine is considered one of the important drugs in the management of heart failure. In addition, of course, to the use of ACE inhibitors and beta blockers. If your heart rate remains to be more than 70, in the presence of already those drugs that I have mentioned, ibabradine should be added to further decrease the heart rate of your patients with congestive heart failure. Unfortunately, if your patient has both heart failure and AFib, you cannot use ibabradine because ibabradine is specifically used for patients with sinus rhythm. So the answer to that question is it can be used in heart failure, but it cannot be used in patients with atrial fibrillation.
But he qualified it paroxysmal.
Oh, paroxysmal.
What if paroxysmal only?
Okay. So paroxysmal, which means the patient has episodic runs of atrial fibrillation. Yeah, especially I think if the patient has predominantly sinus rhythm, I probably would try it, especially if you have maximized already the other drugs that you have used and the patient's heart rate has remained to be elevated, is persistently on sinus rhythm only with paroxysms of AFib, I think you may use it. Just have to monitor that the patient does not go back or does not lead to persistent AFib or permanent AFib, wherein in that case, you might have to discontinue the drug already.
Very good. There's a next question here. This is, I think, primary prevention. What if a patient is at risk for coronary syndrome, high risk? Can you start giving ibabradine and beta blockers right away?
Patient only has high risk for factors without, you have to realize that the indications for use for ibabradine is angina and heart failure. So if it is just a preventive drug therapy, there is no accepted recommendation for that. We have to be specific that ibabradine is useful for heart rate control in patients with heart failure manifestation or anginal manifestation. In the absence of those two, I don't think we can give ibabradine.
Maybe let's put it this way.
Okay.
In the spectrum of chronic coronary syndrome, right? We have mild, moderate, severe, which means the patient can go to acute coronary syndrome. Is there a role for ibabradine and beta blockers across these syndromes? I mean, anytime these patients can go into MI and they can be stable, they can have silent ischemia. Would you use ibabradine or beta blockers as prophylaxis?
As prophylaxis, you mean patients already has diagnosed coronary artery disease? Is that what you're saying? Or just risk factors for atherosclerosis? I think that's two different entities, no? That's two different entities.
You have to answer both if they are diagnosed CAD.
Yes, correct. If they're diagnosed CAD, even in the absence of symptoms, I think there is a role. But if it is just purely risk factors for atherosclerosis without CAD, I don't think we can recommend that.
Correct. Thank you for that. And there's another question. Can you use trimetazidine for acute ischemia?
You really have very different questions. You have very difficult questions, Dr. Eugene.
It's coming from the...
Why are you making me... okay, this is really a very nice... No, I'm impressed with the questions, honestly. That's what I wanted to relate to you. The questions are much more difficult than the questions I have received from the lectures I've given to cardiologists. Oh, okay. So, patients with acute ischemia. Okay.
Right.
Of course, there are no RCTs that I can prove to you that with robust evidence that it can be used. But having said that, what I am going to share you is there's one Korean study, actually, the KAMIR trial, which included patients post-myocardial infarction. No? And the inclusion, the entry criteria was, it's not like acute coronary syndromes per se, but patients who develop ACS, if I'm not mistaken, a few days after, this was a retrospective study. They look at those patients who were given trimetazidine versus those who did not get trimetazidine. Those patients who were given trimetazidine has better reduction of major adverse cardiovascular events. It's known as the KAMIR registry. It's Korean Acute Myocardial Infarction Registry. So there.
Thank you for that.
But we have to be clear, no, Eugene, I just want to make sure that recommendations per se, in terms of guidelines, it's not part of what we should normally give in our patients with acute coronary syndromes. I just want to make sure about that.
There's a quick question here. Can you use ivabradine among patients with MINOCA?
MINOCA. Again, for the same reason, if you're, for the same reason, if you have angina and patients have significant heart rate elevation, I think this is where, again, where I think the value of identifying the pathophysiology of your patients, the cause for why the patient is having myocardial ischemia. I think you can play around with knowing what is the pathophysiology, and if there's, for example, increased heart rate, a patient continues to have some amount of angina, I think there's nothing wrong with giving a drug that can lower the heart rate.
Maybe you can answer this quickly. How do you diagnose the other pathophysiology of ischemia? Non-obstruction.
Okay. Yeah. Okay. So, unfortunately, the diagnosis for microvascular disease is still at this present purely experimental. Most of the diagnostic tests are difficult to do. You're talking about PET. You're talking about doing studies, getting levels of your enzymes during CAT studies to see whether the patient is having microvascular disease or not. In terms of vasospasm, it might be a little bit more, probably a little bit easier to diagnose it. We all know that when we do angiogram and you see signs of vasospasm, some people give acetylcholine or egonopine during the testing, or even just, we've seen this, those interventional cardiologists that are listening, we can see a narrowing, and then we give nitrates during the study and it gets better. That's already a very good sign that the patient has vasospasm. So vasospasm probably is a much easier disease entity to diagnose than microvascular disease. Microvascular is still at this point purely experimental.
Okay, have you come across a study on congenital heart disease using ivabradine?
Congenital heart disease?
Yes.
No.
Congenital, none.
You probably might have, I don't know, you probably, are you aware of any? I know you do a lot of lecture also on ivabradine, so.
Maybe in children, I don't know. What about in hyperthyroidism, ivabradine?
No.
No data.
No, I don't think we should extend that far with the use of ivabradine. No.
Oh, there's a question here. In elderly patients in sinus rhythm with, CCS, would you use ivabradine or ranolazine?
Okay, elderly patient with chronic coronary syndrome, correct? Mm-hmm. Sinus rhythm.
Yes.
Okay.
So the question is, between the two drugs, which one will you use? Ranolazine or ivabradine?
Yeah, that is when you have to think about the patient-tailored approach. That's when you have to look at all the other variables. What is the heart rate of your patient? What is the blood pressure of your patient? What is the echo of your patient? What is the LV function of that patient? If that patient's LV function is bad and has symptoms of heart failure, you might have to favor ivabradine. So my most important thing to remember for all the listeners is look at all the other factors that will make you decide on which drug is best for your patient. There are this small information that might favor one over the other in terms of usage, in terms of making decision of which drug can be used to your patient.
Right. Nice. And this one, the earlier question was about ivabradine on high-risk people for coronary syndrome. What about trimetazidine? Will you recommend its use? For example,
again, for primary prevention, I mean, I'm sorry.
Yes.
Is that the one? No. Again, trimethazidine's indication at this point in time is for, specifically, I'll be specific, is for angina reduction. We have to make that clear. Angina reduction. Your patient should be symptomatic for angina of whatever nature. Okay, it can be angina from coronary artery disease, as we're talking about focal lesion. It can be angina from microvascular disease. It can be angina from even vasospasm. But the patient should be symptomatic of angina.
Okay, thank you for that. And I think there are other important questions here, but
you made me work, Eugene.
Let me pick one that is, I think, very practical. Short of an angiogram, for example, they are in the provinces. How will you suspect that the patient is suffering from vasospastic or microvascular disease?
Okay. The book says that if you cannot explain the symptoms of your patient by other diseases like focal epicardial coronary artery disease or vasospasm, then you have to highly consider microvascular disease, especially the female population. No, so if you think this patient is unlikely to have a epicardial, like if you're talking about a 20-year-old female that looks like ischemic in nature, you have significant ST segment depression, she gets anginal pain, but unlikely to have focal disease or unlikely to have vasospasm, because vasospasm usually has ST segment elevation. Then what I'm saying is, if you have ruled out other etiology and you cannot think of any other etiology because of the difficulty of having it diagnosed, then probably it's a microvascular disease. Second, as I've mentioned, vasospasm is probably a little bit easier. When they get chest pains, usually they have this ST segment elevation that gets better after a while, after treatment with nitrates or calcium channel antagonists. And of course, the easiest etiology to determine is the focal artery disease. No, although, as you said, it's in the province. So focal stenosis would probably be more consistent if you're in the province. It's more of a demand supply thing, no? So a treadmill stress test might be a very good diagnostic test. I hope in that place there's probably a treadmill stress test. But it's usually, if there's really none, exertional angina is very typical of patients with focal arterial stenosis that gets better at rest, no? While sometimes vasospasm is something that occurs at rest. So at the end of the day, you go back to the physical history and the history of the patient, the physical examination, and the history of the patient. Because if you get a good history, you might be able to determine which of these three most common etiology now of myocardial ischemia is possible, despite its difficulty. Okay?
Thank you very much, Dr. John Anunuevo. The other questions are waiting for you to be answered. You will answer them in the chat box. Thank you for
thank you
for the lecture. It was nice, concise, and heartwarming to all of us. And back to the
thank you, Eugene, and thank you to everyone.
Thank you.
Bye-bye.
Okay, welcome to quiz 4. Okay, so our first question. Okay, so here's the ECG. Okay, look at the ECG. And here, when we say what walls are involved in myocardial infarction, sometimes it's actually pretty hard if you look at the ECG versus what's happening in the clinical. But here we are strictly looking at the ECG. Okay, so remember the criteria for the leads that have to be present. Okay, so it has to be contiguous leads, at least 2 contiguous leads. So what walls are involved in this MI? So we diagnose it for you. It's already a myocardial infarction, ST segment elevation, myocardial infarction. But we want to know what walls are involved. Okay. Okay, this is the ECG. Okay, can we show the poll? See the answers. Okay, a lot of you answered anterior and lateral. And actually, the second, so that's 55%. A lot of you also answered anterior, septal, and lateral. Okay, I warned you that you're going to strictly base this on the criteria that it has to be 2 contiguous leads. Okay. So you can see here that V1 in V2 and V1. Okay, V2 there's some ST segment elevation. There was a question initially in the chat box about why we have a higher cutoff for V2 and V3, and that's because in normal ECGs you see some ST segment elevation in V2 and V3 more in males than in females. So that's why you have a higher cutoff. Okay, so here medyo borderline about 2 millimeters, okay, 2 millimeters or more, but definitely V3, V4, V5, and V6 have ST segment elevation, okay, so both anterior, and actually a lot of your lateral, actually all your lateral leads, your V5, V6, 1, and AVL have ST segment elevation. So it's more an anterior and lateral. Ngayon, there could be some septal involvement, but again, I warned you, let's stick to the definitions. Dapat contiguous leads. Okay, and you can see here 3 in AVF and some in lead 2. That's your reciprocal changes. So the answer is anterior and lateral. Okay, so this is our next ECG. Okay, look at where the ST segment elevations are. Okay, so again, has to be contiguous leads. What wall or walls are involved in this myocardial ST segment elevation, myocardial infarction? Anterior, lateral, anterior, septal, or lateral, anterior and lateral, anterior and septal, or inferior. Okay, we can show the poll. Okay, can we see the answers? And a lot of you, majority, 72% answered the right answer, which is inferior. Let's show a bigger version of this ECG. You can see the ST elevation in 2, 3 AVF, which are the inferior leads, and you can see reciprocal changes, okay, in your septal and anterior leads. Okay, so that makes a diagnosis of an ST elevation MI more clear. Okay, so inferior wall myocardial infarction, again, 2-3 AVF ST elevation. Okay, this is our next ECG. Okay, look at your ECG, look at 2-3 AVF, look at your V4, V5, V6. Okay. So you can see, look at your AVR. Okay, that's one clue. Look at your AVR. Okay. So what vessel is likely blocked in this situation? A, left main, B, distal left anterior descending, C, circumflex artery, or D, the right coronary. I think we can show the poll. Okay, can we see the answers? Okay, so not a lot, but majority, 45% answered left main coronary artery. The rest, the second choice is right coronary. The other choices, 17-15%. But a lot of you answered the right answer, so most likely, huh? So let's go to the ECG. And the ECG shows diffuse ischemia, ischemia in the inferior wall, ischemia in the anterior and lateral wall. Okay, and you can see that there's an ST segment elevation in AVR. So there's only several situations that can cause this. It's severe 3-vessel disease. So we didn't show severe 3-vessel disease in the answers. Proximal left anterior descending can cause this. But the other one is occlusion or stenosis of the left main coronary. So that's the only, so that's why I had specified in B, it's the distal left anterior descending. So that's not the answer. It has to be a proximal LAD to show this pattern. So it's either, so diffuse ischemia, either severe 3-vessel disease, so lahat barado, or a proximal LAD can also explain this, or left main coronary stenosis or occlusion. Okay. So surprise, we've decided to add more quiz questions for tomorrow to give you more chances to enter the raffle. Okay. Okay, so let's go to our last lecture, again by Dr. Anunuevo.